Hello, everybody. Welcome back to the Incubator Podcast. We are back at Hot Topics in Neonatology, and we are joined by Dr. Sheri Nemerofsky, who is the Medical Director of Newborn Services at the Children's Hospital of Montefiore Einstein.
Correct.
In the Bronx in New York City. I love people from New York. That's where I trained.
I think sometimes he really misses New York.
I do.
I'm worried that you'll.
I got my daughter.
One day.
This is completely off topic. I got my daughter for her birthday, like literally a Subway plaque. So this is how much like now it's going to be sitting in her bedroom. So this is
all right. Well, don't leave. Okay,
fine.
we're working on something.
Sheri, you were part of the QI day yesterday. Can you tell us a little bit what the discussion was about? What is the topic that you tackled?
Sure. So yesterday I talked about big babies and big opportunities and quality improvement. So it's an exciting field. There are probably half of the group of the neonatologists actually also cover newborn nursery services. And so I also do both sides of neonatology. And I really wanted to show people where we can grow in that field, and there is opportunity. And basically, I went over some of my research.
It's often lost on us that they represent the largest group of babies we care for.
Right. So then that was one of the slides that I highlighted.
Yeah, and I mean that's the takeaway of the group of lectures, Thriving from the Start, Quality Initiatives for Full-Term Newborns, because they're often kind of ignored, I think, in the NICU on a large scale. So tell us a little bit about your work.
Yes, so I will agree with you completely, and I think that actually one of the talks ignited me. I sent over an email to my trainees yesterday who wants to do QI in the NICU for full-term babies, actually, because they are not the same as the premature babies that everybody talks about.
They have their own unique needs.
Exactly. So I talked about, there's almost 3.5 million babies born a year in the United States. So 90% are healthy and in the nursery. So I'm like, that's a huge number. So I really wanted to explain to the group that the babies are there. They're just waiting to be looked at and waiting to improve systems and workflows. So a couple of my recent projects I did was, one was increasing hepatitis B vaccine efficiency. New York State recommends that it's given within the first 12 hours of life. So we were giving it before discharge for most of the babies. So we weren't bad, but usually was in the final hour before leaving.
Yeah.
So it took a bit.
On the way out the door.
Exactly.
The wheelchair.
Exactly. Last one. So so we did this workflow with nurses, with staff. It was interesting. With this workflow, the EMR was the kicker. Having the order, I didn't realize was really such the rate-limiting step. It wasn't like everyone knew about it, but they wouldn't do it without an order.
Yeah, Lindsay Kinnick was talking about that, about like how QI really kicks off once you have the order set.
Yes. But then we also talked yesterday about EMR and QI, that you're supposed to start small. So how do you do that without changing the EMR? It's not so simple to keep making changes, at least in our system, to simple EMRs.
And I think we tend to forget sometimes that there's the option of opting in for an order versus opting out. So like whenever you set up an order set for, admission to the newborn nursery or to the postpartum, like you could have stuff checked in already, and then you can make the conscious decision of saying, well, we're not going to do that, and there's probably a reason. Or the opposite, saying, well, it's going to stay unchecked, and then we're going to ask people to check in. There's huge ramification in terms of buy-in and retainment of the intervention.
No, it's really remarkable. So in that one, it was like, it just shut up.
Yeah.
I really thought educating the teams and the nurses and prenatally would really do it, but it was pretty flat for those.
I want to ask you about the hepatitis B vaccine, just because I'm sure there's other opportunities that you've identified, but it's one, in my opinion, that it must feel challenging in the current climate. There's so much hesitancy towards vaccines, so I'm impressed that you picked this one to because I think that more and more people are saying, if anything, a lot of our patients we're starting to see are quote unquote deferring. They say, "Oh, I'll do it with my pediatrician." I have no clue if they end up doing it at their pediatrician or not.
And it's certainly not in the first 12 hours.
Definitely not. And so I'm just curious as to what is the experience you've had trying to roll out or work on this QI initiative in this current climate.
So that's a great question. So I could tell you in the last 6 months, we're rolling out an RSV initiative. And I thought, okay, I did the hepatitis B one, no problem. I could do this one again. But as you guys know, there's two ways for immunity for the baby. The mom, which would be great, or us. So I'm tracking the mom's getting it and or the baby getting it if necessary. And first of all, I can see I do it by week, and there's some weeks no moms got it. And I'm like, what happened? why that week nobody got it? The next week 5 moms got it, or like what happened? So partly I'm like the prenatal world. I'm like the documentation is they weren't aware it was the season, and I was like, oh my gosh.
Right.
So I was surprised with those partners that I have to like keep up.
Work back there. Yeah.
But as I'm looking at the ones receiving the the antibody for the babies, we're having like a definite decrease in hepatitis B vaccine.
Wow.
So I'm very disappointed.
How one's impacting the other.
Yeah, well,
Yeah.
and I'm not sure. So interesting because I have another colleague. I'm not sure if it's related or not to the timing or this drug, because a colleague of mine says they often give vaccines, the hepatitis B vaccine right before discharge. So it wasn't that 12-hour. So we're actually, different systems have different problems.
Sure.
You know, the same workflow that's going for me isn't going for them, which I was surprised. But yeah, we're usually above 90% on hepatitis, and I think we're sitting at like 88, 87.
That's so
good,
interesting.
yeah.
I'm also intrigued. You know, I think we cross over, so we do some nursery coverage. Not all neonatologists do nursery coverage, but I think you're right. There's so many opportunities. One, about neonatologists working with the newborn nursery, at the very least. One, to keep babies out of the NICU, but two, so many of the things that you are working on, say vaccine acceptance, still trickles down to the NICU, because we're still trying to vaccinate those babies, and we're receiving more and more deferrals. So I think we can learn so much from the work that you're doing. That's incredible.
Yeah. No, thank you very much. Yeah, it's great. And you get to team up with a whole different set of staff.
Yeah.
You know, one of the other initiatives was like safe sleep in the nursery. So we got to get environmental services involved, dietary, because they go in the room, right, to for the food or for the meals.
That's really smart.
As educators of parents.
Right.
I love
or
that.
if they see it, they'll come and tell us. They'll tell the
Wow.
nurses or they'll tell the docs, and they say, oh, this baby's co-sleeping. Oh, this mom was asleep. You know, if they don't want to make that
They're
conversation.
like secret shoppers.
Yeah, exactly.
Yeah, but we were talking about that. We're saying like we're trying to give this education about safe sleep, and then you go around the hospital and you're like, we're not
Correcting
reinforcing
it.
the
Yeah,
right
that's
behaviors.
right.
It's just it's so interesting that you acted on this particular signal. That's kind of cool.
Yeah.
So for trainees listening, early career neos, pediatricians, where are still some opportunities that we have in the nursery and the full-term baby that are still untapped?
So I think we look into a lot of CMV screening and testing. I think that's popular these days right now. And again, full-term babies, most of those babies are asymptomatic if they have CMV. Hearing screens, there's a lot of different workflows. Who does your hearing screen? Is it the nurse? Is it audiology? Or is it a service that comes in?
Yeah.
So there's like a lot of different workflows for that. Because you need follow-up, you need timely follow-up if they don't pass the screening test. So those are the big ones that I can think of off the top of my head that we've been working on. We also are looking at G6PD. New York State has made a new New York health law for G6PD screening.
Very
So that tapped into some social determinants of health a little bit
Sure.
because they only recommended us to screen certain minorities. And I did not like that. So we screen everybody at our hospital.
So as not to miss anybody.
So as not to miss anybody. And actually the cultures were not really well trained in to ask people about their ethnicities and their races and
it's so interesting
cultures.
because in New York, like there's not good segregation of like everybody is mixed together, and so what? How do you define? How do you draw these lines? I have no idea.
That's a perfect answer. So rather than us not really trained to ask the right questions, and then really the patients, we don't want them to feel uncomfortable. They couldn't be honest about it. So we screened, and we actually found in our population more than 6% were positive for G6PD.
Incredible.
Wow.
So, I mean, with that number, everyone should be screened. That's a big number. You know.
Did you have any number for how many you might have missed had you gone the traditional route of screening?
I do, but I don't recall.
Okay.
I apologize. I don't recall.
That's all right.
But you can find my article, and then it will tell
I think
you.
that's such an important point, especially about in screening. Like, are we missing people that we could be identifying because we're not asking the right questions?
I can tell you, 15 or 20% of the positives identified as white. So we would never have screened them if we went by what they said. And so they have that.
Yeah, we have interesting. I mean, if we were asked that exact question, our family history would give you a headache of
Right.
Answering the questions. Yeah.
So no, it's great that you guys are doing that. That's great. Sheri, thank you so much for dropping by the booth,
You're
and
welcome.
congratulations on this work. And we'll see you around the conference.
Thank you so much.
Thank
Nice
you.
meeting you.